Thank you, Nick. So I am Charles Gutteridge. I'm from East London, and I want to tell you the story of East London in probably a little longer than 15 minutes, I'm afraid, Nick, but there you go. Because I think we are further than perhaps sometimes the service is given credit for. George Freeman counseled us to think about data, so my first slide is about data, but it's very, very stark data about East London, which simply shows that if you are the average person in East London, male or female, you lose about 18 to 20 years of good health living in Whitechapel and beyond. And our mission as healthcare providers in East London has been for probably 150 years to deal with that disparity. And I do think we're close to a different kind of system for delivering that. So I think there are three core elements to our program in East London. The first, and I think again Mr. Freeman really emphasized this, we have to create a people's health data movement so that people understand data about themselves, data about their families, and the things that might influence their health. And I'm going to come back to that in my last two slides about some of the practical things we should do, because it's no good just talking about data with people. They won't understand what that's about, but there are some very practical steps we can do. Empowering clinicians at the point of care, that point has been made again this morning, and I think we now have some of the resources that produce population level data to influence policy locally, and it's about driving policy locally that I think makes a huge difference. So what does our information system begin to look like? I'm going to show you a couple of slides about building the learning system, which is about management, how we're beginning to develop data, and then take you through 5 projects. So this is a rather stale slide about management structures, but without a management structure to force, GPs who won't do what Brian Fisher is requiring us to do, my consultant colleagues and so on, to enter data and so on, you have to have a body of management process to make that happen. So I'm not going to take you through that slide, but it's just to say that in East London, I think we have created structures that drive change and of which are coordinating across those barriers of care that, again, Mr. Freeman talked about, because they are very significant. And I think one of the really key institutions that is beginning to deliver change is the Clinical Senate, and I'll just talk about that a little bit later on too. Here is some, again, another management slide about some of the ways you can make change by creating new incentives and doing managerial work. So Tower Hamlets is divided into 8 networks with a clinical lead in charge of each network. There is additional money provided to the clinical lead who can incentivize change at the point of care from general practice. This has begun to really change the way doctors enter data, use data, and analyze their QOF returns in new and productive ways rather than just looking for the handsome pay package at the end of the month. And layered on top of that is our new organization, Barts NHS Trust, which has been in place for 3 years now. The little red jobs are along the north side of the river are the hospitals that basically layer over those management structures that I've just gone through. So there is a key question, I think, for us as local policy deciders, which is to decide whether the current structures are fit for purpose and will they be able to drive change fast enough. There's much out in Twittersville and elsewhere about whether vertical integration of primary and secondary care is a desirable thing, and I won't answer that question today, but those are the sort of questions that I think we need to start to tackle at a policy level. So let me take you into the 5 data projects. The first is about smoking. So the London Clinical Senate in March asked us all as clinicians to do something about smoking. I think you all know, almost everybody in this room will be a non-smoker. Yet many people out there are smokers. And if we were to do one thing nationally to save lives, it would be to prevent smoking. So there's the instructions from the Senate. What have we done locally? This is about data, and it is so simple, it almost makes one cry. So in our electronic health record, the sensible doctor enters the SNOMED term, the structured data term for smoking, and also the data term for referral to the smoking cessation clinic. If they do that, that automatically generates a referral in the community to the smoking cessation clinic. So in 2 clicks, one can create a referral for every patient who smokes. Of course, they won't all stop smoking, but at least we have a data-driven pathway for making that happen. Just a little bit more data about smoking, because I think this is encouraging about East London. On the whole, women who are pregnant don't smoke. So only 5% of our currently pregnant women smoke. We have the data on that. It's 1,300 people. All of those women have had at least a conversation about smoking, because that's recorded in the electronic health record, and we know their carbon monoxide levels. The sad thing is that only about 50% of the women have taken on the referral that we've offered them. So we've got some work to do in providing information. The next program I want to share with you is our integrated care program. Using the data sets that Brian Fisher and Peter Sowerby and others have built into things like the EMIS record, we now apply a risk algorithm to each electronic record in primary care, and which generates a data set for us, which we then identify usually elderly people, but people at risk of admission to hospital for common comorbid conditions. And we flag those into our electronic health record in the hospital with the aim of reducing emergency admissions by adding new pathways, reducing the admissions into hospital by alerting our doctors in the emergency department to the presence of those patients, and we hope in the longer term, improving outcomes. We've got a natural experiment to sort of test some of the things that we're doing in pathway design. So East London is mainly made up of Waltham Forest, Newham and Tower Hamlets. In Waltham Forest, we have community matrons that go out to each patient's home and do face-to-face enrollment into this program and ask patients for their permission to enter the program. The system is different in Newham and Tower Hamlets. There, a little bit of technology is used. It's called the phone, but we phone them up and say, would you like to enter this program, and explain what it's about and so on. The data is held in different systems in primary care, some of which hold care plans, some of which don't, but the direction is for each patient to have an electronic care plan, which they will hold in an electronic system that they will have. And then I've already emphasized that we will feed back information to care pathway leaders and also back to general practice and into our population health management systems, the data that we derive from patients. Now, what do we know so far from that? So this is another data slide, and it's unbelievably simple. And you'd think, well, what are you going to do with that? And of course, we do puzzle about that. So we know that each person that comes to the emergency department has at least one bit of data added to their record as part of the rules that we have for attending the admission. 56% of those patients have one of those symptoms or conditions when they attend. Pain, shortness of breath, generally unwell, and so on. What could we do with that data to alter the way people use hospitals? It is too hard to begin to work that out. If they get admitted and discharged, we get slightly more granular data. So we get some ICD-10 codes, lower respiratory tract infection, urinary tract infection, and so on. But you'll see at the bottom the curse of ICD-10, the way that we classify disease, that most of the conditions are unspecified. So that is pretty useless data to try and help us drive change in the health economy. So here's our next project, and this is my only computing technical slide. All right, so there's a young Tyro computer genius explaining to the pharaoh, what do you mean by binary? And what I mean in our world is that unless our clinicians start to use structured data a little bit more, we won't get to understand the two previous slides that I've shown you about how people present. So we've done something slightly different. Using those high-risk patients that we've identified, we've looked at the patients who attend multiply over the year. So just using one cohort of patients, we know that 510 of them attended more than 4 times in a 6-month period. And we've used the data in the electronic health record because all of our docs love putting in free narrative text. They won't follow my instructions to use SNOMED, this structured stuff that you can compute on and analyze. So we've done it for them by doing natural language processing using a great little machine called CliniThink, and begun to analyze free text looking for data that might explain why patients come to hospital. And here's the output of that. This is very preliminary data. We've only done it this year. But the data set is enriched by looking at free text. So we begin to see that people who don't have carers, don't have support at home, who may have substance abuse problems, and so on. And we extend the range of information about why people come to hospital. Now, you might say, why does that matter? And the reason it matters is that using the data, so the answer is probably in the data, we can see with an 83% predictive accuracy those patients who are likely to attend in the next 6 months. Now, that really does mean that you can start to make interventions at home before people come to hospital and change the way they manage their health and the way that we support them with health carers. One very detailed slide, because I think often people believe there is no technology in the NHS and none of it works. And it's a shocking lie. It really is a shocking lie. We have great technology and we use it. So this slide is a screenshot of our electronic health record, and which allows me, in the box at the top left-hand side from your view, to see most of the summarized information in the GP record. So it logs on to the GP record, extracts a summary for me. I can be in my outpatient clinic, on an inpatient ward, wandering around somewhere in the hospital, and see data from a GP record. So you might say, well, what does the GP get to see? The GP gets to see the letters that I've sent, so outpatient letters. They can see the record of the patient's attendance in outpatients and inpatients, and also various discharge summaries from the emergency department and so on. This is, from a clinical point of view, a life-transforming tool, and it's a life-transforming tool with a patient if you use the screen. So at the moment, patients can't get into that record from their homes, but if you sit with them and go through this data and show them how those bits of information work for me as a thinking doctor, change happens. So 2 last slides, and these are the ones about learning. So I don't think the learning point starts with handing people data. It starts with education. So we have this great facility in East London called the Centre of the Cell. It's a learning experience for small children and teenage children who come in and learn about their health, about science, and about the interaction of science and health. And our aim is that every child in East London who is at school gets at least one visit during their school life, both in primary and secondary care, to this facility. And if you in West London want to come, you're invited as well. So do make use of this facility because it's bookable. And then the last thing is a really exciting generational health program for new migrants into East London. It's part of the Wellcome Trust 100,000 Genome Project. We're hoping and have a plan to do the genomics on every family in East London, or at least 100,000 of them, and build up a knowledge base of their genomics, their illness, and use the data in the electronic health record as phenotypic data to match the genomic data that will be generated by this program. But there's a massive educational program behind this screen that brings people into understanding why genomic screening is important, and equally why phenotypic population of the health record is important. Thank you very much.